There are things you are not supposed to say in medicine, not because they are untrue, because they are true in a way that the profession has no vocabulary for, no framework to contain, no peer-reviewed category to file them into. They live in the gap between what science can measure and what a human being can witness, and the gap is wider than most people who have not stood at an operating table for 26 years would ever believe. I am going to say one of those things now. I am going to say it because I am 63 years old, and I have spent the last 9 years since it happened trying to find a version of the story that would satisfy me scientifically, and I cannot find one, and I am tired of trying. I am going to say it because the alternative is to carry it alone for whatever years remain to me. And I have decided that is a worse outcome than the professional embarrassment of being a neurosurgeon who admits that he saw something inside a human skull that had no business being there. My name is Dr. Raymond Osei. I practiced neurosurgery for 26 years, the last 18 of them as the head of the neurosurgical department at a major academic medical center in the Southeast. I have performed over 3,000 cranial surgeries. I have operated on glioblastomas, aneurysms, arteriovenous malformations, epidural hematomas, subdural collections, tumors of every variety and disposition. I have spent more hours inside the human brain than most people spend inside their own homes in a year. I know what belongs there. I know what the dura looks like when you open it. I know the color and texture of healthy cortex, the way an aneurysm dome catches the light of the surgical microscope, the specific gray-pink of brain tissue under retraction, the way blood moves in the sulci, the way a tumor declares itself by its consistency and its vascularity, and the way the surrounding tissue reacts to its presence. I know all of this the way a carpenter knows wood, not just intellectually, but in the hands, in the body, in the particular knowledge that accumulates over decades of doing the same precise and demanding thing. I know what belongs inside a human skull. What I found inside Marcus Webb's skull on the 14th of March did not belong there. I need to give you the medical context before I give you the event, because the event is impossible to understand without it, and I want you to understand it completely. Marcus Webb was 44 years old when he was referred to my service. He was a high school football coach from a town about 2 hours east of the city, a physically large man, 6'3", broad-shouldered, the kind of person whose physical presence registers before anything else. He had been experiencing progressive neurological symptoms for approximately 8 months before his primary care physician finally ordered the imaging that landed him in my office. The MRI was unambiguous. There was a mass in the right temporal lobe, approximately 4 centimeters in its largest dimension, with surrounding edema and the characteristic ring enhancement pattern that in a 44-year-old male with progressive neurological decline meant one thing with near clinical certainty: glioblastoma multiforme, grade 4, the most aggressive primary brain tumor that exists. I sat with Marcus and his wife Denise in my office for 90 minutes on the day I gave them the diagnosis. In 26 years of neurosurgery, I have had that conversation more times than I can count, and it never becomes routine. There is no version of telling a 44-year-old man that he has a median survival of 15 months that becomes easy or procedural. Marcus sat across from me with his hands on his knees, and he listened to everything I said, and then he asked 3 questions about his children, about his ability to continue coaching through treatment, about pain, and they were the 3 most important questions, and they were asked in exactly the right order, which told me something about who he was. We scheduled surgery for 2 weeks out. The goal was maximal safe resection. We would remove as much of the tumor as possible without sacrificing neurological function, and then hand him off to neuro-oncology for concurrent chemoradiation. It would not cure him. We both understood that. The goal was time and quality, not cure, and I was honest with him about that distinction. The morning of surgery, Marcus was calm in a way that genuinely surprised me. Most patients facing craniotomy for a high-grade glioma have a particular quality of controlled fear. Managed, functional, but present. Marcus did not have it. He was sitting up on the gurney when I came in for the preoperative visit, and he was looking out the window at the parking garage, and he said, without turning, "I had a dream last night that everything was going to be fine. Tell me about it, I said, because pre-operative psychological state matters, and because he said it in a way that seemed like he needed to say it. I was in a field, he said. It was night, and there was a man standing at the edge of the field, at the tree line, and he was just watching, not threatening, just there. Marcus paused. I knew him. In the dream, I knew exactly who he was. But when I woke up, I couldn't remember. I just remembered that he said it was going to be fine. Dreams have a way of doing that, I said. Yeah. He turned from the window then and looked at me with those steady dark eyes. Do you believe in that? In things you can't explain? I told him what I told every patient who asked me that question in 26 years, that I believed in the data in front of me, and that the data said he had an excellent surgical team and the best available technology, and we were going to give him every advantage we could. It was not an answer to his question. He knew it wasn't, and he let it go. The way perceptive people let inadequate answers go when they understand that the person giving them cannot do better. We took him to the OR at 7:15. The surgery began well. We positioned him in the lateral decubitus position with the right hemisphere up, fixed his head in the Mayfield clamp, prepped and draped in the standard fashion. I made the skin incision, turned the bone flap, opened the dura in the standard cruciate fashion. The cortical surface looked as the imaging had predicted. The gyri were flattened in the area of the mass, the underlying tissue discolored in the way tumor-infiltrated brain becomes discolored, the surface vascularity altered. We navigated to the tumor using intraoperative neuronavigation. We began the resection. For the first 2 hours, everything was exactly what it should have been. The tumor had the consistency of a high-grade glioma, soft, highly vascular, friable in the way GBM tissue is friable. The borders blurred and indistinct where it infiltrated into functional tissue. My resident, Dr. Anaya Krishnamurthy, was assisting, and we worked in the particular focused silence of a surgical team that knows what it is doing, the scrub tech anticipating instrument needs, the anesthesiologist maintaining the parameters we needed. Then I reached the deep margin. Every neurosurgeon who has operated on a significant-sized temporal lobe tumor knows that moment when you have resected through the bulk of the mass and you are approaching the deep structures, the structures that border the brainstem and the basal ganglia and the thalamus, the structures where the margin between adequate resection and permanent neurological devastation narrows to millimeters. You slow down, you look more carefully, you let the microscope do more of the work. I let the microscope do more of the work, and under the magnification of the operating microscope, at the deep margin of Marcus Webb's tumor, I saw something that made me stop. I have described what I saw many times in my own mind, privately, over the 9 years since it happened. I have tried on many different descriptions. None of them are adequate because none of them exist inside the vocabulary of neurosurgery, and that inadequacy is itself part of what I am telling you. What I saw at the deep margin of the tumor, in the tissue immediately adjacent to the posterior temporal and occipital junction, was a structure that I had never seen before. Not in 3,000 cranial surgeries, not in training, not in any anatomical atlas or intraoperative photograph or surgical video I had ever reviewed. It was approximately 8 millimeters in its largest dimension. It was not brain tissue, not normal brain tissue, not tumor-infiltrated tissue, not scar tissue from prior injury, not any of the pathological tissue variants I have encountered in 26 years. It had a distinct boundary, which tumors virtually never have at their deep margins, and it was a color that I have never been able to accurately describe. Not quite white, not quite luminescent, not gray, not pink, not any color I have a precise name for, but which, under the operating microscope, seemed to generate rather than reflect the light falling on it. I stopped operating. Dr. Krishnamurthy, who had been watching through the teaching scope, said nothing for a moment. Then she said very quietly, "Dr. Osei, what is that?" "I don't know," I said. "Those 3 words are not words I say easily in the operating room. In 26 years, I had said them perhaps 4 times, always about a vascular anomaly or an unusual anatomical variant, things that were surprising but ultimately explicable. I said them now about something that was not surprising in the way of an unusual anatomical variant. It was surprising in a deeper way, in the way of something that should not be in the category of things that exist. I looked at it for a long time through the microscope. I changed the magnification twice. I asked the scrub tech to adjust the overhead light. I asked the circulating nurse to call my colleague, Dr. Patricia Wren, a senior neurosurgeon who had been in the department for 22 years, and ask her to come to OR3 when she had a moment. Patricia came in 6 minutes later, changed into a mask and gloves, and looked through the scope. She was quiet for longer than Krishnamurthy had been. Then she said, "I've never seen anything like that." "Neither have I said. "What does it feel like?" she asked, meaning with the instruments. In surgery, you know tissue partly through touch, through the feedback that comes through the instruments. And that tactile knowledge is part of how you identify what you are looking at. "I haven't touched it," I said. She looked at me through her mask. I could see the question in her eyes. Why not? And I did not have a good answer. I did not touch it because something about it made touching it feel wrong in a way I could not articulate. And I have thought about that instinct many times since, and I still cannot fully explain it. I can only tell you that in 26 years of operating, I had developed a set of instincts that I trusted completely, and every one of those instincts told me not to touch what I was looking at. Patricia straightened up from the scope. She looked at me again. Then she nodded once, a nod that said something between "I understand" and "I cannot help you," and she left the room. I made the decision that I have questioned every day since. I closed around it. I left it in place. I completed the resection of the tumor tissue surrounding it, achieving what the navigation confirmed was a gross, total resection of the enhancing component. The structure at the deep margin was untouched, bordered on all sides by the resection cavity, but itself intact. And I closed the dura, replaced the bone flap, closed the scalp in layers, and brought Marcus Webb out of anesthesia. He woke up at his neurological baseline. No deficits. His speech was clear, his motor function intact, his cognition unimpaired. He recognized Denise when she came into the recovery room, and he made a joke I have forgotten, but that made her laugh, and the laugh was the sound of a woman who has been holding her breath for 6 hours and has finally been given permission to exhale. The post-operative MRI, done the following morning, showed gross total resection of the enhancing mass. And at the deep margin of the resection cavity, in the area of the posterior temporal occipital junction, there was nothing. No residual enhancement, no unusual signal, no evidence of any structure that differed from the surrounding brain parenchyma. Nothing. Whatever I had seen under the operating microscope was not visible on post-operative MRI, which should be impossible. 8 millimeters of anything, tissue, fluid, air, foreign body, pathological structure of any kind, is visible on a 3 Tesla MRI. 8 millimeters is well above the resolution threshold of the imaging we use. If it had been there, it would have shown up. It did not show up. I called the radiologist myself. I asked her to review the sequences again, specifically the area I described. She called me back in an hour and told me the area was unremarkable. She asked if I was concerned about a residual. I told her no, the resection was complete. I did not tell her what I was actually looking for. I have never told anyone what I was looking for except Patricia, who has never brought it up since, and Dr. Krishnamurthy, who came to my office 3 days after the surgery and sat down and looked at me with the particular expression of someone who needs to ask a question they are not sure they are allowed to ask. "The thing in the deep margin," she said. "Yes," I said. "It's not in the operative note," she said. It was not in the operative note. I had dictated the standard note: approach, resection, hemostasis, closure. Patient tolerated the procedure well. And I had not included what I saw in the deep margin because I had no language to include it in, no pathological category to assign it to, and because to include it would have been to create a permanent medical record of something I could not explain and could not substantiate with any objective data. I am not proud of that decision. I know, I said. Krishnamurthy sat with that for a moment. Then she said, "Do you think it was an artifact? Scope light? Something with the magnification?" "No," I said. "Neither do I," she said. She left my office and we never discussed it again. Now I need to tell you what happened to Marcus Webb, because what happened to Marcus Webb is the part of the story that I cannot account for at all, not even with the most liberal application of every scientific framework I have tried to apply to it. Glioblastoma multiforme, even with gross total resection followed by the STUP protocol, concurrent temozolomide and radiation, has a median overall survival of approximately 15 months. The 5-year survival rate is under 10%. These are not pessimistic statistics. They are the most current and accurate data available, drawn from thousands of patients across dozens of institutional trials. GBM is what it is. It is the most lethal primary brain tumor in adults, and no amount of surgical skill or aggressive adjuvant therapy has substantially moved those numbers in the past 2 decades, despite enormous effort. Marcus Webb is alive. He is 53 years old. He is 9 years post-diagnosis of a biopsy-confirmed IDH wild-type glioblastoma multiforme, grade 4. He still coaches football. His most recent MRI, I reviewed it myself at his request 3 months ago, shows no evidence of recurrence. The resection cavity is clean. The surrounding brain is healthy. There is no enhancement, no new signal abnormality, no evidence of any process that should not be there. There is also no evidence of the structure I saw in the deep margin. His neuro-oncologist, a colleague I trust without reservation, reviewed his entire case last year for a departmental conference on long-term GBM survivors. He described Marcus as statistically inexplicable. He used that phrase precisely, as statistically inexplicable, and then presented the possible biological explanations. Super responder phenotype, unusual molecular profile, immune-mediated tumor control, all legitimate scientific considerations, all things that exist and have been documented. None of them explain the survival curve Marcus Webb was sitting on. I sat in the back of that conference room and I listened to my colleague present the case of a man I had opened up 9 years before and left something alone inside, and I thought about what I had seen under the operating microscope, and I thought about what Marcus had said to me the morning of surgery. There was a man standing at the edge of the field. I knew him. He said it was going to be fine. I am not a religious man. I was raised in a household that attended church, and I carried the form of that faith into my adult life without examining it too carefully. And somewhere in my 40s, the examination happened, and I was left with something more spare and uncertain than what I had started with. I believe in something. I am honest enough with myself to acknowledge that 26 years in the human brain have not left me with pure materialism, because pure materialism cannot account for what I have witnessed at the extremes of neurological experience. But I do not have a theology. I do not have a name for what I believe in. I have a memory of 8 millimeters of something under a surgical microscope that generated its own light and disappeared from the post-operative imaging and left behind a man who should be dead and is not. I have thought about what that structure might have been. I have thought about it with the full rigor of a scientist, working through every possible explanation systematically. Artifact of illumination. I have operated under surgical microscopes for 26 years and know every artifact they produce. This was not one of them. Unusual tumor component. I have operated on hundreds of GBMs and know their deep margins intimately. This was structurally unlike anything I have encountered. Surgical instrument contamination. The instruments were sterile and the scrub tech had not introduced anything to the field. Tissue from the overlying resection. I had removed the bulk of the tumor before reaching the deep margin. The only tissue at the deep margin was what was at the deep margin. Every explanation I construct fails, and so I am left with the thing I started with. Something was in Marcus Webb's brain that I cannot explain, and Marcus Webb is alive 9 years after a diagnosis that should have killed him inside of 2, and those 2 facts are connected in a way I cannot prove and cannot ignore. I told Marcus about it. I drove 2 hours east on a Saturday in October, and I sat in his kitchen and his wife made coffee, and I told him what I had seen and what I had not included in the operative note, and what the post-operative imaging had shown. He listened to all of it without interrupting. Then he was quiet for a moment, looking at his coffee cup. Then he said, The man at the edge of the field. Yes, I said. I still don't remember who he was, Marcus said. In the dream. I knew him and then I woke up and it was gone. He looked up at me, but I remember what he looked like. He was made of light, not glowing, made of it, like light was what he was made of instead of whatever we're made of. I looked at my coffee cup. 8 millimeters, I said. Yeah, said Marcus. We sat in that kitchen for a long time without talking. His wife moved around us refilling coffee and not asking questions, the way a woman who has watched her husband survive the unsurvivable learns to move around the silences that come after. I drove home as the sun went down, through 2 hours of flat interstate and fading light, and I thought about what I know and what I don't know and the specific shape of the gap between them. I have held human brains in my hands. I know them the way you know anything you have spent a lifetime learning, in the bones, in the body, below the level of language. I know what belongs there and what does not. I know the difference between what I can explain and what I cannot. I cannot explain what I found inside Marcus Webb. I cannot explain why he is alive. I cannot explain 8 millimeters of something that generated its own light and disappeared from the post-operative imaging and left behind a man who coaches football 9 years after his death sentence was handed down. I am 63 years old. I have 3,000 surgeries behind me and whatever remains in front of me, and I have decided that the most honest thing I can do with what I saw in OR3 on the 14th of March is say it out loud, exactly as it was, without the protective scaffolding of clinical language, and without the false comfort of pretending I have an explanation. I do not have an explanation. I have a memory, and I have Marcus Webb, alive and entirely inexplicable. 2 hours east of here, coaching the second quarter of a game that by every measure available to me should have ended 9 years ago. I think about that corner of his brain sometimes, late at night, when the cases of the day have settled and the house is quiet, and I am left with only what I know and what I believe, and the narrow, impossible, luminous distance between them. 8 millimeters, made of light.